This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus.
Hey everybody, thank you so much for tuning in for a new episode of the Defocus Media podcast. We're coming at you live again tonight, and this is a topic that's really near and dear to my heart because as a myopic person that now has a child and sees patients that are myopic and have to talk to parents, this is something that day in, day out, I feel like we are charged as optometrists to help spread the word and offer this technology. And the technology for myopia control, where when I started practicing 10 years ago, it was not really there. It wasn't FDA. There wasn't anything that we could really truly offer with FDA approval, right? The research, the technology is there. We have all the tools and they are easy to fit. They're easy to utilize. The hardest part becomes talking to parents and changing that mindset of what is status quo for prescribing. So we're going to have that conversation tonight from people who are doing it really, really well. Please welcome to the show, Dr. Stephanie Tsang and Dr. Justin Kwan.
Hi, everyone.
Thank you.
Dr. Kwan, why don't you get us kicked off tonight telling us about yourself. We're a private practice owner and then transferred over to senior manager of myopia management at CooperVision.
Yeah, thanks, Jen. So we'll go back to, I guess, optometry school days. Graduated in 2009. And for any residents or students watching out there, I actually didn't match to my residency, but it came out for the better because I got a secondary kind of a hybrid, you could say, a dry eye and contact lens kind of research fellowship at SCCO. And then after that, I taught there for 7 or 8 years. And then fortunate enough to join the vision source practice of Dr. Pamela Lowe in Chicago here. Spent about 1.5 years. And you know how they always say, like, if you're new and trying to find a job, like reach out to your reps. They know what's going on in the hundreds of practices. Well, my rep from SoCal reached out to me, and that's how I was able to find out about this position at CooperVision. And I applied that same night. It was really right around the eve of that MiSight FDA approval. And 6 interviews later, got an offer in February of 2020 and then started during COVID. So that's it in a nutshell. Yeah.
What made you so passionate about myopia that you saw an opening for myopia management and you're like, that's me, I'm in?
Yeah, I think some of us get approached or get tantalized by industry, maybe 3 years out of school, 5 years out, and we're like, oh, we would really, really miss patient care. And I really do still. But I felt like, some other optometrists do something different every 10 years. And I felt like, okay, 10, 11 years out of school, I was ready to try something different. And like you said, Jen, FDA approval for MiSight only comes around once ever. And so I kind of had to seize that opportunity, which I think was that motivation. And my wife and I are -10, and we have a 5 and a 3-year-old as well. And just getting the care for so many patients over the years, it really is one of the most rewarding things.
Dr. Tsang, tell us about yourself. You were at Golden Vision San Francisco Optometry, and you had made the decision to buy into that practice. So what was your path to optometry ownership?
All right, thank you. Hi, everyone. I'll rewind it back like Dr. Kwan here. And so I actually graduated in SCCO in 2012 and was one of Dr. Kwan's students. Wow. And so it's like things come back full circle, and it's been really fun to kind of talk to him. And as we're kind of growing this together, we chat with each other frequently. And yeah, he was our resident contact lens and dry eye guru. And so it was really fun. So yeah, I started off, in school, really enjoying kids and kind of younger people and older people and kind of figuring out what I wanted to do. I did a residency then in kind of low vision off disease. And then when I came out, I got this opportunity to work with Golden Vision and really got exposed to contact lenses, and then just really quickly realized how rewarding both professionally and personally that it is, because you really just follow these people through their journey and you can really connect with them and it resonates with you really easily. It's very rare to have something where in healthcare, you get an immediate benefit, but also a long-term, most people, you say you got diabetes, nobody wants to eat the good stuff, right? It's hard to get that honed in, but you get kind of compliance built in when you can tell the kid, hey, you're going to see really well, and this is really good for you, home run for mom and kid. And so it's been really, really fun. And when it comes to the practice, it was kind of a gradual and natural transition, but I've always really enjoyed just kind of figuring out the nooks and crannies, how to smooth out things and figure out better processes, and just really enjoyed the opportunity learning under a lot of different people much smarter than me. And so when we got that opportunity, we took over the practice right before COVID. So very interesting time. Had my son in the same year. And so it's been a ride, but it's been fun. And, you just keep looking to develop good care and together as a community, with things that you do and go from there. So it's been fun.
It's amazing. So from early on in your career, had you been a big proponent of myopia management options, or is this something that you've only recently been exploring?
I've pretty much been doing it for about a decade now. Mm-hmm. And, you grow with it. And that's the cool thing. It's, you can really learn and challenge yourself beyond what you start with. And then you can learn all the little nuances, how other kind of more complex cases, and take on other things. And there's a lot to start with. But for everybody listening, I mean, you can start off low, and there's so many people needing this care, mm-hmm. and not enough practitioners really doing it. And so as the paradigm shifts, it's really fun to be a part of that kind of tipping point, and having tools in our toolbox now that are FDA approved, that we can talk to not just parents, but also pediatricians and ophthalmologists about, and really have that backup and say, hey, it's FDA approved. We have all this research. I mean, a lot of people might come at you and say, oh, isn't this really new? But honestly, we've been doing it for decades. I mean, atropine use has been in Taiwan 30 years ago. It's not anything new, and we feel very safe. And we're just at a point where it's more accessible and much more easily accessible.
Yeah.
You're diving right in. This is exactly the topic we want to talk about today, because we are, all of us, maybe some of an exception to the norm, where for a decade in our careers, we have been practicing myopia management, but the conversations 10 years ago were a lot different, because everything was off label. Everything was more challenging to present research and studies for, where they didn't feel like they were getting a bunch of other alternative opinions from pediatricians or MDs. So have you noticed in your practice that the patient conversations are changing in the last year or two?
I have definitely noticed that. And it's interesting because there's actually a cultural component to it, because I'm lucky enough to have worked in an area where I think a lot of people knew about Orthoke. But then I'm now in San Francisco. I mean, it's a very microclimate. And so no matter what city you're in, the population that you're serving, it might be a little different, right? The amount of myopia in that population is different. And the parents, then what they know about myopia and what it means to them is different. And so even in the South Bay Area versus the San Francisco Bay Area, which is a little bit more diverse in that particular practice, I have different conversations, which may be much more entry level and just saying, hey, did you know this exists? Versus having parents coming in and asking me specifically about it, because they're coming in from China and they've been doing it. They embrace it a lot more over there, just because they have 90% myopic versus 40 something, right? Sure. So yes, it's, but having that awareness and the acceptance has definitely changed across the board. I don't know if Dr. Kwan has any other thoughts on that.
Yeah, I think from where I sit, it's really been rewarding to see how the practice of optometry is so different across the country. And certainly, having been to Heart of America conference a couple weekends ago, really seeing maybe the families, whether socioeconomic or what have you, want to just chew off like a quarterly supply, and they really benefit from that. Whereas annual program all the way towards the coasts, right? And whatever gets treatment and lenses onto the kids' eyes, is what we want, right? Because the sooner the better. So it really, like Dr. Tsang says, spans all kinds of communities, cultures, and socioeconomic as well.
Thank you so much, Jenny, for engaging us. This is a great comment. I agreed with you about the microclimates. You see this so much in your own patients, and Justin, that's what your point is coming towards too. Like in different parts of the country, the way you have to have the conversations and the way you have to present these options are different, because where annual upfront supplies might be working in one area, breaking it down into quarterly installments or paying by the visit works better in others. So everything that we are giving as advice on what's working in our practice, we all have to kind of take with some nuance, because your patients may not respond in the same way. But that's why I think it's so great to get 3 different minds together to kind of see where there are common grounds and where we may be able to rethink and learn from each other, right?
Yeah.
Let's talk about some of the biggest challenges that you face when you present myopia management to parents. In your practice, what do you see, Dr. Tsang?
I would kind of split this into a couple fronts, right? One is when I took over the practice, it was a very, contact lens glasses, refraction, right? Not a lot of medical, not a lot of myopia control, not even a lot of dry eye. And that's great. But as coming into parents, you're educating not just your parents and your patients, but also your staff and your other doctors. And I think the key thing is one of the biggest things you'll hear is cost, right? And then the second thing is, what is this and does it even work? And so I think I like to just really approach it. Every person is the same. So even though we are discussing microclimates or different socioeconomic levels or different ethnicities and genetic histories, if we're treating a glaucoma patient, do I approach it any different? I look at my risk factors, I assess my risk level, and then I give my treatment options, right? And then up to the patient, they get to do what they want. And so we work as a team, and I try to have a very open and honest discussion with each family, right? And I don't want to point out just the parents and then ignore the kid, or just talk to the kid and ignore mom and say, hey, this is what you need. And, so it's a team effort, and it needs to start as a team effort from the very beginning. And that's what makes it fun. That's how you get to know them. So some of the key words I would say is, hey, this is concerning. Axial length, I mention a lot, right? If you can come first with, that's a concept that we're having a paradigm shift amongst ourselves as a community, as well as parents. And they probably never heard of it, even as us who are all myopic. We grew up and said, I was used to just every year I go to the doctor, my prescription increased, I got a new pair of glasses. I never actually wore Ortho-K. There are patients our age that did wear Ortho-K as kids, which is awesome, but I didn't know about it. And, just kind of starting with the basics is like, hey, prescription increased, and this is concerning because the axial length is now longer. And what does that mean? Really kind of ease in the conversation.
Yeah. I mean, even looking at all 3 of us, like, we don't know if you're 27, you're a 26, I'm a 20, and so on. And so that concept is like, everything looks fine because we're all wearing our full correction and contact lenses, right, but yet the underlying disease is continuing to get worse, right? So that is a very new concept, I'd say.
I agree. I think where I've had more success, and this has been a recent mindset shift, we've always been, like you said, so focused on, well, I'm a -2 or a -4. And like, that's how you discuss myopia with parents, is with these numbers. But they, at the end of the day, don't have a real sense of what's even going on in myopia. So when you start talking about axial length, that really paints a picture of like, why can't I see? And a simple picture is all it takes, and a parent will immediately grasp it. But just that one picture of normal eye, myopic eye, and they're like, oh, I totally get it, and now I understand like what it is we're trying to do with this. And so it doesn't have to be a long discussion. Sometimes when we think about talking about axial length with a parent, it's like, well, this is going to get into too much. Just that one picture, and it changes the whole conversation.
Yeah, Jen, that's exactly what we found out on our parent focus group research, is that the parent that saw that diagram, they said, I don't want that longer eye for my child, right? Like whether stretch marks or, whatever you want to call it, that just doesn't seem like a good thing, right?
Yeah, I use the balloon analogy a lot. I mean, that's easy for people to, you have your picture and then you're like, it's just a balloon stretching out,
And I love that where it avoids scare tactics. It avoids pictures of retinal detachments or something where we're going into a negative conversation. But it's just a straightforward, clean diagram. And you can easily piggyback off of what, for example, on the MySide website, they have a diagram of the way the contact lens works with the bullseye effects. And you can, like, now they've seen a diagram of the eye. Then when you show them that, it's like, oh, and here, this couple's with it. So it helps you build your conversation well as too. So I'm thrilled that parents also agreed because it seems like it's been working in my practice.
Oh, that's good. Yeah, we always say there's a solution to the problem, right? And that's really what they want to hear is that, oh, I have this power to, make a difference now, and it's a 2-in-1 benefit, right? Like Dr. Tsang said earlier.
Yeah, I think parents get very overwhelmed. I mean, you're all parents of young children. We're all here. I kind of joined the thing, but we're inundated with social media and how we should be raising the kid. And you got to do this, and you got to swaddle, and you got to not do this, and you got to feed like this. And I think parents don't want an extra layer of stress on top of them. So what really resonates is just, hey, there's something concerning about your kid's eyes. We can do something about it. These are your options, and you can choose what works for you.
I think we also have to be mindful of a big challenge. Every single person in our society is extremely well educated. They have access to all the information in the world at their fingertips, and they go into any doctor's appointment equipped with expectations of, I will get these things that I've researched and I know about, and I will, we see this in optical sales a lot of times. If you wait till the exam to have the conversation to educate patients about things, the patient's already made their buying decisions before they ever walk into your door that day. So don't think you're going to be changing anything during the exam, okay? But we do this in our own lives too. We have expectations when we go to the doctor, and we get what we expected to come out with. But a parent comes into the exam with the expectation of, my kid's eyes going to have gotten worse. They're complaining to me about their distance vision, and we'll be getting the new glasses prescription. You present something totally different. That's a lot to take in, and no wonder there's going to be some apprehension and some pushback. So we need to kind of understand where the parent's coming from, that you are not meeting their expectation of what was going to happen at today's visit, and that's uncomfortable for them.
Yeah. And I think, of course, I do mention things like, hey, retinal detachment or glaucoma, but it's very glossed over. It's more so the idea that, and it resonates with whether I always ask the parent, mom and dad, do you guys have glasses? How high of a myope roughly are you? Because then you have a much better gauge, because, your -10 parent who had a laser scar from a retinal hole is going to already understand retinal detachment. It's not going to scare them. I don't believe in scaring the child. And plus, you might be having a conversation with the parent about something very normal, and then the kid hears that they're going to get a hole in their eye, and they might get really scared. And so you don't, it's like someone says a glaucoma suspect, and you send them for referral, and you didn't clearly explain to them that they're a low risk suspect. They're going to sit there for 4 months thinking they have glaucoma, scaring themselves if they're a hypochondriac or anything like that. So we have to be very empathetic with what we are presenting. And I think that'll be much more effective than saying you're definitely going to get glaucoma, which is not true, or a retinal hole.
Right.
I mean, earlier on, I was all, because, I present these things, parents seem kind of disinterested. I was like, look, you're at this XX% increased risk of retinal detachment. You're at this XX% risk of glaucoma. Like, it was a part of my conversation. Because I wanted to express, like, I'm concerned. I want to help protect you from these things. And one day, the kid started bawling, like so upset, and I was like, oh my gosh, like you don't have those things. I'm so sorry. Like, I'm not trying to worry. I just want to help you. But I mean, it was an absolute disaster. And so if anyone has not had that experience yet, you do want to help help people. It's good to educate about the risks, but maybe lay off of how strong you come on with that part of it.
Yeah, I've definitely been there too. And I said, oh, if we don't do something, you're going to lose vision. And then everybody just froze. And then I like had a desperate attempt to save myself. It's like, well, not everybody that smokes gets lung cancer or like,
Yeah.
Backtrack.
I mean, that's what we're worried about. Like I want them to understand the risk. That's part of why we should do it. But it's just how you approach the conversation. It can be positive or it can be negative, and you're always going to do better with positive conversation.
Absolutely. And whether us or the staff does it, like if the child plays soccer and gymnastics, like parents want to give them that edge, right? Whether it's like vision or exercising, stretching, getting stronger, getting better at their skills. Like this is a part of that to help them succeed in their activities that should be fun, right? And the fun part is the best part of the job, right?
Well, let's talk about pushback, because I think if you're presenting this to patients as an option, you're invariably going to get parents pushing back to you about why should I care? Why should I get involved? And I want to talk through some examples I've had in my office and how you guys as experts would have approached and addressed these. So this is a classic one I'm sure you've heard many, many times. Myopia isn't a big deal. My kid can just get LASIK when they get older. What do you respond to when you hear that?
Go ahead, Steph.
All right. I simply say I get it, because I had LASIK. I'm myopic. I can. You want to share your experiences or share your thoughts, but you also want to empathize and say, I understand where you're coming from, but there's this kind of paradigm shift, or try to understand that, hey, there's new technology that's out and there's new studies that are out that kind of really show us that, wearing glasses is not just about the prescription, but there's more to it. Again, now the axial length stuff kind of comes in and said, hey, we're looking at, as your doctor, we're looking at things kind of from a health perspective, and we really want what's best for your child. And there is a lot of studies that now show that this increase in myopia is significant for X, Y, and Z reasons. And maybe if you want to do LASIK, the kid can't do LASIK until after, 18 to 21. And if that prescription is more than a -10, right? Or if their cornea is too thin, they might not be a candidate to do LASIK, right? So there's realities with the situation that you need to kind of show to them. And then just
I use that as well in my practice. I'm like, yes, my goal is to make sure they're a candidate to get that LASIK, because, if we're changing too fast, we'll be outside of that as an opportunity. And that helps that conversation quite a bit.
Yeah. And I think in that case, if the parents did have LASIK as a -5 or whatnot, that might be the situation where you show that their nerve is a little tilted with some PPA, and then their child's optomap or retinal photo is not tilted, right? And so there's a comparison there that, hey, you got LASIK, so fix the symptom, but your eye is still longer than it should be. And that's where I bring myself in, right? Because we know the OCT normative database is not good for high myopes and tilted nerves. And so I'm like, I got to get my baseline at age 35 and then just compare subsequent years to myself, right? And so that's a change in the medical optometry for my own management. So I think what I'm trying to say is, a lot of people subscribe to myopia management is lifelong. It's not just when you're stabilizing your myopia, right? There's implications down the road that we'll continue managing even as adults.
Yeah, for sure.
Another one that is common to hear was, my kid's too young for contact lenses. And I'm a big proponent of contact lenses for young kids, but I'll be surprised sometimes for parents to tell me that and their kids in high school. And I'll still hear that. So what have you guys seen in your practice?
Can I start off with a question? Just what's the youngest contact lens fit or Ortho-K fit that you guys have kind of seen and been comfortable with? Because that might, the listeners may have.
Yeah, I think that's the best way to bring it up. I had a 5-year-old -11. She obviously was a genetic, not your school-age myopia, but her triplet brothers did not have myopia. So my youngest was a 5-year-old, which I put into a corneal GP multifocal. Yeah.
That's incredible. I've also had a 5-year-old. Mom was an extremely high myop, around the -15 range, and at 5 they were already a -4. And mom, obviously with her history, was very much like, yes, the child was not doing insertion and removal. Mom was taking care of everything about it, and it was very successful. So I think you can do young when you have parent buy-in.
Mm-hmm.
100%. So I think that comes back to our team effort thing, right? Is I tell them, hey, I have kids as young as 10, and then I have kids that are 15 that mom and dad are still inserting for them, and that's fine, whatever works. But it does, I think we have to read our patients a little bit, and that'll come with a little bit of experience. I think for anybody who's starting myopia control, you probably want to patient select, at least in the beginning, get your comfort level up, and then you'll start doing other cases, because you'll start seeing that the need is in there, and then you go younger and younger. And but again, team effort, and kind of know the realities of what to expect. But we have done it. I mean, in fact, sometimes on some patients who are really skeptical, we have people with pediatric contacts. People don't know that babies can be in contacts, right?
Absolutely.
Yeah,
that's a great point.
And, any of you listening that know Dr. Takea Locke in Georgia, she has a 4-year-old in my site, obviously off label, but parents put it in, the 4-year-old takes it out. She's a minus, I think, 1.75. And so she is fully dependent on vision correction. She enjoys it, and she's motivated for removal, and we'll get to insertion in probably another 6 months, right? But yeah, we are so excited that our YouTube channel for my site has kids showing other kids how to insert and remove. So it's like, oh, if I see another kid doing it, maybe I could do it, right? Because there's the parent's concern, and then the child may be disinterested until they get that wow factor, or they watch that video and they're like, oh my gosh, I can make the hockey team if I wear contact lenses or what have you too. So it's on all fronts, yeah.
That is so great. So kids doing the insertion and removal videos. I'm going to immediately start directing my patients to that. So
yeah, we have 3 videos on different kids doing it now. Yeah, it's amazing. Actually 4. I think a set of twins, a boy, another girl, and another girl. Yeah.
It's a really neat concept, because they really, resonate with that.
Yeah.
I think, like you said, you've got to involve the whole family. Everyone needs to be on the same page. I always defer to parents. I was like, you're the parent, when your child is ready and when you as a family are ready. So I want to make sure that they understand, like, we're only moving forward when you want to move forward. I'm here to assist you and to help you do what you guys want to do. But then, like you said, providing those examples, and if I could send them a video via email of a kid doing it, that would be even better. So I'm going to start doing that now.
Yeah, that's awesome. Yeah, there's no one size fit all. And so just kind of understanding that. I had a family who the younger daughter did Orthokeratology, but then the older son, who has sleep issues and sleep apnea, does my site, because he can't sleep. He doesn't sleep. And that's what worked for them. And, we roll with that. And that's awesome.
This is one where it sounds like you guys do a lot of the same kind of pushback too, but a parent says, does this really work? I need to know the science. I need you to show me what it's doing and how it's working. And like immediately you're like, oh my gosh, this is really am I going to sit here and explain peripheral defocus? Because it's not going to go good, but any advice on how to do this without having a 1-hour CE lecture happen?
I can kick off. Yeah. So, part of the 2-page parent agreements we provide, parents like, okay, read this. I kind of understand. There's some ownership I'm taking on. One line we have in there is, of course, slowing of progression is expected, but not guaranteed, right? And we don't know if the child's going to be a fast progressor, a slow progressor, or be in the middle of the bell curve of our 144 kids in the study. So that really just elevates the importance of watching them every 6 months, and knowing that, there could be something to celebrate, but if we need to pivot, we can, and we will, and we'll help out every step of the way. One of our other colleagues, Dr. Christy Locke, she's like, man, when they came back for the 6-month visit with my site, like, I got some high fives. Like, it's really something to celebrate. So that was the litmus test, right? It was like, could it actually go from a -1 shift in the previous year, stabilize, or just a quarter at the 6 month, and then we can kind of celebrate every step of the way.
I think being realistic, nothing is 100%. There's nothing in healthcare that can be 100%. We don't have that kind of control. I'm not sure we want that kind of control. Yes, we would like it, but it's a lot. But you're gonna get some parents that are super engineer and want every little detail, and then you're gonna some parents, all they need to hear is that it's been around for 30 years and building up. It's been decades. It's not just a brand new thing that you're just hearing right off the bat. Mm-hmm. And so I think again, understanding what your patient is truly asking you and what they're looking for to kind of get that answer kind of driven to them. But we have studies on site, and we can print out a little sheet and say, hey, for the people who are wanting a little more detail, this is what it is. But if you really want like a one-liner about my defocus, there are some people who I will tell them, oh, we're basically using lenses to put the image in front of the eye instead of behind the eye. Mm-hmm. It's something as simple as that, is probably as technical as you would want to get in.
Okay. Same thing. I agree. We have a printed out pamphlet or page of study data links. So if you have someone who wants to dive in and read clinical studies, you provided that resource, right? But then you don't have to go into the studies during your myopia consultation or your comprehensive exam. But I mean, I've tried this so many different ways to limited success. And what I've actually found is working best for me right now is the MySight picture with the purple rings on the contact lens. And I would just pull that up and it's like, this is how this contact lens works. Do you see all those rings? A regular contact lens is just the same. This lens has the rings in it, and the rings are what slow things down. And I don't get any, y'all think oh, they want the science, right? And I always think I need to go into the technical details, and it gets to be too much and too confusing. But that one picture answered all the questions is what I find. And then we offer orthokeratology as well. I was like, it's the exact same. It works with those same rings. So then you don't have to have two separate conversations. Yeah. It's the exact same thing, just two different ways of wearing the contact lens, basically.
Yeah. Another way to say what you just did, Jen, is for my set at least, one part of the lens helps your child see clearly. The other part of the lens slows the growth of the eye.
Love it.
As simple as that.
Love it. Yeah. Thank you, Dr. That's a perfect takeaway. All right, one more patient pushback I want to talk to you guys for. So I have this happen all the time. Parents came in, they were motivated to do contact lenses this year. And they were, we start talking about options. Their myopia had increased. I was like, well, we can do contact lenses to slow down this change. They're like, maybe next year. Let's just do regular contact lenses. How do you address that?
Yeah, another objection there is let's just wait to see how it goes, right? So we usually will say or point out that their child is growing, right? Their shoe size has gotten bigger, their pants are getting shorter, as I heard another doctor say. And so when your child's growing, their eye is growing. It's pretty much a guarantee, whether you mark their height on the wall or the pediatrician tells you they're growing. So we could wait, but we don't want to wait a full year because we can't get back any of that time. We can't undo what's already been done. And because every unit of stretching matters, right? We got to intervene sooner than later because it's almost like this finite window of time to do the best good we can. So we kind of start out by saying it's assured that they're in elementary school, they're growing. So if you want to wait a year, my bet is that they're going to get worse, right? And that, at least in the MySight study, the kids got worse 96% of the time without treatment. Yeah.
To play devil's advocate, and I do say that all the time. I say your kid's growing, this kind of 7 to 15 age range is really the most rapid growth. And so we want to do something within this time period, right? And we want to be more aggressive as soon as we find it, because we can find that the studies find that it's more effective that way, right? And we want to hit it when it's young and early. But I flip it out. And when you said that just now out loud, Dr. Kwan, I thought, as a parent, hey, if it's normal for them to grow, why isn't it normal for their eye to grow?
Yeah.
And so why wouldn't I wait and see? And so I think bringing in, if you're lucky enough to have the tools or anything like that, understanding that risk factor and saying, hey, you got a -4 and you're already a 26, and then a normal eye is 24. you're already way longer than you should be. Yes, it's normal for them to be growing, but you're already outside the normal. So we got to be a little more proactive now versus if I was at a 50 and they were a 23. Then I might be a little more lenient and say, maybe let's not wait a year. Maybe I'm happy to bring you back in 3 to 6 months and just see if, this is the first eye exam and you need to digest it. Can we bring you back in 3 to 6 months just to see if he's one of those rapid growth people?
Sure.
I very rarely, if I see a young myope, I shouldn't say allow, but I will never recommend that they come back in a year without treatment, because I'd be happy to at least see them for if you do no charge consult, why not just book them for a no charge consult in 6 months? And if they change, you check the VA and the AL, you didn't do anything, you spent 10 minutes. But I think that that's a good thing to do. And you may be able to convert sooner than later. And for the child, it's much better because they understand that a year is a long time. A year is what the insurance company dictated, not what should be.
I love that, where it's normal to grow. It's not normal to grow as fast as their eyes are growing. So,
and we know kids with myopia, their axial length grows 2 to 3 times faster than emmetropes do. And another doctor would say, your 7-year-old is aging faster than they should. They're already well beyond, going back to if you don't have the 26 or the 24 millimeter numbers to compare, that's concerning, as we said earlier. But it's funny because I met a doctor in Portland last week that did say up in Portland, some of these families would be like, we don't want to inhibit what's normal, or
that's the normal pushback right here.
Sounds about right.
We want nature to take its path. Yeah,
exactly. So
I think that's when we have to tell.
A good way to, maybe figure out how to answer that one. Really,
I would say, is it normal for us? What's normal, right? You look back and we should be playing out in fields. We're not supposed to be in houses.
That's what the problem is, right? Is that we're not allowing ourselves to be normal, and we're looking at screens and we're staying indoors all day. So normal's out the window now.
So we got to sometimes pull back and say, okay, this is biologically not normal. Everything that we're doing is not normal.
But also, I know we have to be sometimes careful to not say the child themselves is abnormal, right? That can be triggering, right? But that this growth or this is faster than it should be, and maybe that avoids the abnormal word,
Well, let's talk about that. I mean, we talked about how important it is to get staff involved, to get the whole team interested and excited. But how do you make talking about myopia management fun and positive in your practice with a whole staff involved around that? Any keys to kind of making this fun and approachable?
Shall I start? Right. Okay. I think you need to first convince yourself, and then it comes top down, and your passion will show and the importance will show. But I think for staff, the key thing is just keeping it real simple. They've got a lot going on. They're great. You appreciate them in their right hand. You don't want to just put on more stuff. So as simple as saying, under this age, everybody under this age, ask if they know about this, and then I will talk about it. I think the cool things as you kind of dive in more is being able to do hands-on stuff with staff. As they start to see the cases coming in, they get to share the cases. You get to share the success with them. Be excited about, little Jimmy came in 6 months later and the prescription didn't change, and he had changed before, exactly like what Dr. Kwan said. So as soon as they build up that experience and see that the kids coming in for their 1 day and 1 week follow-ups are loving their vision, and they can see the kids' confidence and smile, like you had a crying kid on day 1 and oh my gosh, you came back and you did great last night, good job. The staff themselves start to build confidence. And so, it comes top down. But I had one time where I just kind of blocked off some schedule time and had all of them kind of fit and do some trials and training themselves, put on a lens or choose something, because you don't have to do it in just kids, right? They can kind of get an idea of it. So getting them involved in the process, celebrating with everybody is, again, positivity. you attract more honey, more bee with honey. Right?
Yeah. And I've heard like doctors bring staff into the room during the consultation so they can hear and almost like mirror or emulate the doctor and how they answer questions once they're more seasoned in managing a lot of kids. And Jen, I actually learned this from you. Like if you do like a team huddle or a once a month meeting, like you can just say like, in our practice, we don't let myopia get worse, right? Simple as that. Or in our practice, we don't prescribe single vision for children that are growing. And this is why, though, right? And it comes back to demonstrating that elongation and stretching. But if a staff member has myopia or has kids with myopia and have been in my site, that's still the strongest testimonial, I think, hands down, right?
100%. I think the moms moms or dads in your staff they can really understand it. And I think just staff training in general, what do you do to train them on anything else, right? It'd be great to have them run through beginning to end the patient journey in your office and see everything. And then, but you kind of pick and choose what to do in the beginning. And then once you're able to, you get them through and see this whole journey. And then afterwards, reinforce it. Because it's really easy for them to forget because there's so many different things that they do.
Yeah.
Let's talk a little bit about different ways of managing myopia. And we had talked about we've been doing this from prior to having FDA approved treatment options. You've had parents come in specifically requesting Ortho-K. I know I have that in my practice as well. Now that we have more options, right? It sometimes becomes difficult to differentiate, like who should I talk to Ortho-K about versus who should I talk to my site about when we've been doing Ortho-K for so long, and by comparison, my site's relatively new. Dr. Tsang, how do you approach that in your practice?
Oh, I kind of have the conversation and I propose it kind of on an equal playing field. Like, hey, as from my point of view, I want to keep your eyeball from getting longer, and there's these great tools and we are at this great time. And, there's pros and cons, some parents might be just terrified of a nighttime routine. Maybe they're a single parent family, and they can't imagine, half the week I can help put it on, but the other half of the week, I don't think my partner can, or, my ex-partner can put on the lenses. And I've had a patient very kind of openly and honestly tell me that. And so if that's the case, hey, you got my site. Well, you got nothing to, that's something a little bit easier. Just kind of understanding your patient and letting them know the pros and cons of a soft lens during the day versus a hard lens at night. And I think they will kind of show you the way. You don't have to decide for them.
Mm-hmm. Yeah, I think there, some practices adopt like a good, better, best. And Kate Gifford has like shown it on like a first place, second place, third place platform for efficacy. But that's going to be a lot of information that's overwhelming, like we said earlier, too. And so at least from the International Myopia Institute, kind of third party, they usually say to start with a non-label option first if they're a candidate, or at least inform the parent, right? And we could still go to Ortho-K because they're water polo, swimmer, or whatnot. But at least, definitely hit on that because it's available. But there is some efficacy kind of tiers. And then there's like a third party validation of that as well to be less biased by company, right? Yeah.
I mean, I also present to my patients roughly all these treatment options are equally effective. There different studies say different things about percentages. We really can't compare them all head to head because there's not been a study that's done that in a controlled way. So every option I'm presenting to you would be an effective way for us to approach myopia control, pros and cons. I personally, as a doctor, I encourage you to do this if you are kind of curious. I've worn Ortho-K before. I talk a lot about my experience as an Ortho-K wearer and some of the things I liked about it and some of the things I didn't like about it. And I from my own experience, I will say I probably skew a lot more towards my site because the comfort and the convenience and the easiness of it on the patient side of things, if all things are being equal in their candidacy, it is going to be probably a little bit easier to get used to for the kid. But in some instances, there's situations where like actually Ortho-K is a better option for them. Certain amounts of astigmatism, for example, and things like that. So, you've got to take it patient by patient. But I think giving patients multiple choices actually is helpful in this case. Mm-hmm. So it's, you're letting the parent pick and have a conversation with you about what's going to be best for them and their lifestyles.
Yeah. it's going to be that much more effective or easy when they go home, because they could do phenomenal with INR in the office, but if they struggle at home, that's almost a non-starter, right? Yeah.
Any go-to orthokeratology lenses that you think are great for practitioners wanting to get started in that side of things?
Oh, there's so many things out there now. I'm not gonna be on the book. I think it's like scleral lenses. Whatever you use, you're gonna have to learn how to fit, and then just kind of start with that and just dig right in. And then if you get good at that, you can always figure out other options if for some reason the treatment got maxed out or something like that. Yeah.
And since you did mention the astigmatism, Paragon CRT dual axis can address up to 150, 175 astigmatism. And my personal highest when I was at SECO in the clinic was a 14-year-old. She was -7 with 250 corneal sill. And the IC lens was able to get her down to 2020.
Wow.
Yeah, so that was like definitely one we celebrated. Yeah.
Mm-hmm. Yeah. I mean, there's a lot of great things. I think toricity is the next step in ortho-K control, right? And figuring out all that. And there's all sorts of, maybe we'll be able to map the eye better and do all these other kind of treatments, right? Mm-hmm. But I think starting area, I mean, CRT, all of those, they make it really easy coming in. You do a topography, you do anything, and you've got your consultants, you got really good reps and things like that. So it makes it quite easy to fit. Just like with RGP and other things, we shouldn't stray from that. That's something that optometry we taught to do, and we can do it if we're just doing, generic or off the shelf soft lenses forever. It's not really going to set ourselves apart. Yeah.
And Dr. Kwan, correct me if I'm wrong, but I mean, my sight's only up to -6.
Yes, and we hope to have a power range expansion hopefully later this summer. And so that will go to a -650 and a 7. I think in other parts of the world, they'll potentially have up to -10, which is exciting. So,
whoa.
yeah.
That's awesome.
But darn, the FDA only kept us at -7 for now. Yeah.
Every little bit helps. So we're just, I mean, thrilled to hear that there might be even
I think by my math, that might help another 900,000 kids in the US. So, yeah.
Right.
Amazing.
Yeah.
Do they have ideas on when it's going to come to -10 or?
At the US, there's no timeline, but I think in Canada and Europe, they're going to have it a little bit sooner, potentially this year. Yeah.
Wow. Canadian doctors, you guys are always so special. So much stuff to enjoy up there.
Yeah.
So Dr. Kwan, actually, this is a perfect segue because we want to get an update on what's coming in 2022. And we actually have a question from our audience. Dr. Schuster wrote in, any word on when or if my site may be available to docs who practice in Costco?
Yeah, absolutely. We almost have weekly to monthly conversations with the leadership at Costco. And so we hope to, again, bring that into Costco by the end of 2022. But sometimes those conversations and the power is not in our hands. We would absolutely make every single decision to increase access. And we absolutely want the doctor-patient relationship to remain intact for all our Costco sublease doctors as well. So more to come. Hopefully we can have good news by the end of 2022.
Any updates on certification or what that process is looking like now?
Yeah, that's a really exciting thing. We're doing monthly certifications over Zoom now, just once a month. So you can still do the self-paced 5 lessons like Jen and Stephanie did, or you can hop onto our Zoom once a month. So ask your Cooper Vision rep or reach out to me. I'd be happy to get you registered for one of those. We're doing a live certification at SECO to anybody that's planning to come to New Orleans. And yeah, it's becoming easier and it's open to all. Yeah.
So all doctors,
private
practice, corporate,
all staff, all
everybody
students.
certified.
Yeah. In fact, one optometry school has made MySight certification mandatory in their 3rd year contact lens 2 course. So we're super excited about that. Yeah.
Fantastic.
That's neat.
So optometry students, you can get certified too and be ready to go right from the start.
It's a resume builder to start.
Oh,
there
yeah.
you go.
Yeah. And you don't need to retest or recertify after graduation. You pass it as a student, you take that with you when you practice. Yeah.
What about ordering lenses? Because this is the one thing where, as much as like we huddle with our team and everything, when I go to have a MySight patient, they need to buy more contact lenses. It's very confusing to my staff sometimes, and they get a little bit bogged down about how to order.
Yeah, so we've tried to make that more simple and more like ordering any other CooperVision product. So what that means is you can get it from your authorized distributors, whether it's ABB, WVA, or what have you. You can also order on CooperVision.com practitioner website. And so that's like an e-commerce, looks sort of like Amazon. You just select it in the drop-down. You could get a 180 pack, an annual supply, or a 90 pack even, for some parts that need that quarterly incremental, purchase. And all those ship for free directly to the family's home. And then you could always pick up the phone if you want to and call in an order as well. And the mysightApp.com still exists if you want that central portal to track your patients. But 4 ways to order, essentially, and do what's easiest for your practice.
So as of now, I could order 90 packs for my patients.
Yes.
Oh, great.
Yeah.
I can't wait to get back to the office and tell everybody tomorrow I got to update my system.
We do call it a quarterly supply because we want to keep the spirit of the program, that this is an annual treatment that's going to be more than a year. So some doctors might be like 90 pack, that's like, but it's still a program, it's just helping the doctor, helping the patients, perhaps for those that need it.
I have, you guys were doing a little bit of a rebate before. Do we have any word if that's coming back, or?
From talking to the marketing team, we hope to bring it back for the back to school time period. But yeah, what Stephanie's referring to are the $200 prescription savings cards. So kind of you can earn your way up to those and then help out. And we've heard that, let's say a family has like a son and a daughter, siblings that both need MySight, that $200 prescription savings card was a huge like lifesaver, right? So yeah, we hope to bring those back at some point.
Very nice.
What about the research? Because that's one thing that's been really awesome about MySight. Really robust data that you continually are presenting on. And I think that the body of evidence that we can keep turning back towards it, just continually re-energizing the need.
Quick
Share
plug.
us a little bit about some upcoming posters and data.
Yeah, so quick plug. About a month ago, the 6-year results got published in a peer-reviewed paper in Optometry Vision Science, the Academy's journal. So you can get the pre-publication right now for free. It's open access. The 6-year paper has really great stuff. Some of the things are essentially, every year a child wears MySight, you cut that progression by about half, and we're talking axial elongation. So you don't really get those diminishing returns where, you see some studies get the most bang in the first year, then less and less and less. So not with MySight. There's this proportional effect, and MySight works in 90% of kids, and we were able to extract some of these things because the control group did get flipped into MySight at the start of year 4. So there was a ton of learnings that came out of that. So definitely hit me up for more of those nuggets. Yeah.
That's amazing. Thank you guys so much for sharing so much really great data and insights today. If you guys are on the show and you're wanting to learn more about myopia management, I'm putting up the website for CooperVision. What's cool about Cooper is, yes, there's MySight, but you also have multiple, we talked about IC and Paragon Orthokeratology lenses. It is a full suite of specialty contact lens options that you can learn about there. So you can provide as much or as many of these options to your patients as you'd like to. Any closing words of inspiration that you guys would like to share while we wrap up the shows tonight, so that tomorrow morning when we're seeing patients first thing on Friday, we are energized about what we can do to help?
Yeah, I'll go first. Just know that, whether it's World Council of Optometry or whoever it is supporting the standard of care, you have that backing. You have the backing of the American Academy of Pediatrics, the American Academy of Ophthalmology. So just be excited about this, embracing the standard of care and differentiating, and optometry is alive and well. Myopia management is that gift to optometry, as many have said, and your revenue per patient is going to be there. So you don't have to be so sad about declining vision care plan reimbursements or what have you. There is so much hope, and this is the most prevalent disease we'll treat in our careers. So much to be excited, and to get to meet all these families in your practices and continue with them for years. And so that's really, I think, what excites me.
Yeah. Totally. I think this is a major public health issue of our time, and we get to be so much a part of that. We're the key a part of that, but we get to bring people together, and sometimes we just have to switch it on in our brain and look for it, and you'll realize how much of it is in your practice, even though you may not have realized. And just start small, and it's awesome that we have all of these tools available for everybody.
That's great. I totally agree with you guys, obviously. And I wanted to share a story, Dr. Kwan, you mentioned about the backing of the American Ophthalmology Academy and the Pediatric Association. I had, for the first time ever, our LASIK surgeon in the local community, his neighbor referred to our practice for her 2 children that were myopic to pursue myopia control. So this is a true partnership that we're getting embraced by the entire MD community. So like, hey, let's get on board with offering this care. And so I was really thankful for that referral, Dr. Porter. And if we can work closely with LASIK surgeons to help make manageable prescriptions in adults, it's a win for everybody.
Yeah, it's music to my ears.
All right. Thank you guys as always for your time. We'll be back with a new episode. But until then, have fun out there and keep loving what you do.
Thanks, Jen.
Thank you.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the D-Focus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms. Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at D-Focus Media on all platforms. And until next time, be sure to keep it 2020. And we look forward to seeing you on the next episode.